It's been a long journey, but a really enjoyable one at Goal 3, and I'm very grateful for this opportunity to now today present to you my thesis, Yes, We Care, How Health Workers in Low Resource Settings Get Stuck and Can Escape Capability Traps. You can also look up the slides for yourself to read along, and this link is also posted in the Microsoft Teams chat. So since this topic is probably not very familiar to, I think, everybody except Nika Jelle in this chat, I want to start off with a quote that deeply impressed me. This quote was from the second nurse I interviewed, and she said, "It's not enough. It's really not enough. We have one thermometer that's used for 12 babies. 15 babies have to share one oximeter, while critical babies are supposed to be monitored all the time." So there's a really big scarcity of essential equipment and knowledge that's there. But before I actually zoom into my thesis topic a bit further, I want to zoom out a bit and look at the really big picture. And to do that, I have to start with the Sustainable Development Goals from the United Nations, which are adopted in 2015 and aim to ensure that by 2030 everybody enjoys peace and prosperity, and especially the countries that are furthest behind should be prioritized. And these 17 SDGs, as they're called, are integrated. So it's a circle with 17 goals, and action in one area will actually affect outcomes in all the others. And developments must balance social, economic, and environmental sustainability. To then zoom in into the third goal, the goal which Goal 3, the company, was named after, and look specifically to the part of the neonates that focuses on ending preventable deaths of newborns, with all countries aiming to reduce the neonatal mortality to at least 12 per 1,000 live births by 2030. So how is it going with this SDG and then the neonatal part? Well, there is something called an SDG tracker, which actually collects data and shows these trends over time. And it helps people to hold their governments accountable. And I actually plotted the neonatal mortality rates of the countries that came across in my study. And here you see that, like lately, these neonatal mortalities have been going down a lot. However, this was mainly due to that access to the healthcare system in the countries has improved. So people are able to find the care that they need right now, but now the care facilities cannot actually manage this high demand, and it's really there's a really big need for higher quality of care. So Crook et al. Wrote an article about time for equality revolutions in healthcare in low resource settings. To now cover a bit of the topics of my study. First, I will further take you along within this complex context, and I will cover definitions of a low resource setting and what I see as neonatal healthcare. Then I'll cover the research setup, how I approached it, what this capability trap model actually is and how it's applied in the study context, my results. And at last, I will discuss the implications that my study has. So to start with this low resource settings, and luckily there was a paper by Van Zyl et al. From 2021 that described 9 themes that cover a low resource settings. And these 9 themes are very strongly interrelated with each other, and the severity of these themes makes it extra challenging in such a low resource setting. So let's take a look at their model, and I will zoom in for a moment and start here at the bottom. For example, the influence of beliefs and practices that are very local there, the culture. That's something that can actually hinder progress in such a setting from our Western point of view. And therefore, it's very difficult to get things moving. There's also human resource limitations. So there's just too few people with the right skills in order to do the jobs that are necessary to be done. There's paucity of knowledge. So there's some knowledge, however, there's simply not enough knowledge in order to become productive. Also, there's financial shortages. And at last, I will touch upon the research challenges and considerations, because I also experienced quite some challenges during this thesis work, which I will share with you in a few slides. However, this framework as a whole really helped me a lot because it allowed me to scope my thesis a bit further. And I decided to focus on the topics human resource limitations and paucity of knowledge inside of a hospital ward, since that's something that a hospital has a certain control over. So what happens inside of a hospital ward? Well, to do that, I started to make a process flow of the activities at such a ward. And as quality guru Edward Deming would say, if you can't describe what you're doing as a process, you don't really know what you're doing. So to start off with a high-level overview of a ward, that starts with admission, then daily care at a ward, and then discharge. And at admissions, we have as inputs very sick patients with varying complications like an infection or premature babies. And we have consumables like medicine, foods, fluids, bandages, etc. And as outputs of a ward, we have recovered patients. Sometimes they're still even disabled when they leave the ward, or they need to be referred for a higher level of care. And unfortunately, we also have deceased patients. And I was really doubting whether I should make an icon for a deceased patient, because it's quite intense if a baby dies under your care, if you can't really do anything about that. And therefore I want to take this pause, because that's the reality that's actually happening there. That's where these neonatal mortality rates come from. But I felt that I also had to put it in there, because this is really this balance, what getting better healthcare is really about. We need to heal the patients. So as the customer of this ward process is the patient itself, which has then a whole life ahead of it, and the family and the caregiver of the patient. So if we actually take a look at this ward process in more detail, I made a process map for several actors. So the patients, the caregivers, the nurse, who plays a big role in this process, and the doctor who comes by, and internal suppliers. And by that I mean the laboratory for blood tests, pharmacy for medicine, and imaging and radiology. And this patient healing flow can be modeled as follows. And so here the sick baby comes in, several treatments are started and supportive services are used with these medical consumables that they get in. And then the doctor evaluates and escalates, and in the end, a patient is discharged, most of the time luckily alive, but there can also be a discharge scene of a passed away baby. So that having done that, I hope you get a bit more of the context now in which my study is set. I will cover my research setup. So the research question I had was, how can health workers in low resource setting get the most out of the limited human and knowledge resources? And to do that, I had an inductive case study approach. And I had 19 interviews in totals with 3 workshops, many casual conversations, and I had a tour in a neonatal intensive care unit in the Netherlands. And actually, like my informants, I had to make most out of the means available. In order for me to interview the Tanzanian nurses, the most accessible way was for them to have a video chat on WhatsApp and actually say, okay, how this is going. And sometimes there were connection delays that I had to wait for 20 minutes over a whole hour in order for the connection to get back up. And then there was this language barrier that either I did not understand their English or vice versa. One time also my interview got disrupted because the nurse in the evening had to put her own kids to bed. And then I was just saying, okay, I'll wait. And 20 minutes later, we continued the interview. So that was a very new setting for me, which was quite challenging. But I was very grateful for these nurses to spend their time with me, because their insights were, I think, some of the most valuable insights that I got from this thesis. And I also analyzed my data by some process maps that you just saw. I used the Gioia method and causal loop diagramming from systems thinking. So now let's see how I actually did those last 2 methods. So I collected a lot of data and I labeled this data with several codes. And from these codes, I generated first order concepts that came by quite frequently. And these first order concepts I could further cluster towards second order teams. That's what you see here. And then these were related, these teams I could relate together as aggregate dimensions. And this way I actually have a rigid data structure that I could present. However, this data structure shows a very static picture, what's in reality something very dynamic that I was interested in studying on the ward. So luckily, these loops, these themes and these dimensions were very similar to a model described by Lenijs and Sturman called the capability trap. And this is the final model that I came up with. So the struggle and develop loop relates to this aggregate dimension from the data structure, etc. So before I want to take you a bit further across my model, I want to highlight this archetype that's there from literature. So Repenning and Sturman developed this theory of a capabilities web to explain how process improvement programs fail. And that's a bit of the background, how it was originally developed within manufacturing. So before you can really understand what I'm saying, I feel I also should share a bit on how to reach such a causal loop diagram, because it might look very simplistic, but there's actually quite some nuances in there. So the minuses and the pluses at the arrowheads indicate the polarity of the causal links. So these are all causal links on how that works further. And these links together also form a loop. That's what you see this icon in the middle. So we have 3 loops in total. Here's the working harder, the working smarter loop that goes all the way around, and the reinvestment or ruin loop in the archetype. And these boxes at the top represent the stocks, and the arrows with valves represent the flows, and the stock can only change because of the flows. And maybe before I move on to the next slide, one example of how such a causal loop works with the working harder loop. If there's more work effort, we have more performance. If there's more performance, we have less performance shortfall. And if we have less performance shortfall, we have less work effort. And then this is a balancing effect, because we started with more work effort and then we ended up with less work effort. Last slide on the background. So the structure we are interested in right now is ward capability. And the definition of a capability is a set of routines that enable an organization to produce a particular output given a set of inputs and targets. And I'm sorry. The set of routines I highlighted in the process maps a few slides back. And the output is really the healing of the patient's population. And the inputs that a ward gets is sick patients and these medical consumables. And the targets very simply put, are less diseased patients and more recovered, to make sure that this healing really flourishes. And capabilities in theory have also been used to explain heterogeneity between different organizations in the same fields. Okay, so now let's take a look at the model I created. So I actually set the performance measure to adequate attendance of care. And this is a mouthful, but I did that because I was both talking of human resource limitation and paucity of knowledge. So a health worker must be present, hence need to be at the bedside, and the health worker needs to possess specialized knowledge in order to adequately attend care for a neonate. And nurse 4 characterized it as follows. Neonates need very special care. Monitoring adults is different. A baby cannot talk. So you really need to observe and have this understanding of what's happening with this patient and how can we treat this patient at best. Then, however, there is a big demand for this care because a lot of patients actually, there's a lot of care demand currently going on. And there's also a big shortage of staff, so this gap that's over here is further decreased because the demand is simply way higher than the adequate attendance of care possible right now. So nurse 1 relates to this gap, saying drugs are sometimes forgotten or delayed or administered in the wrong way because of lack of knowledge. Different medicines have different dilutions, and when the drip is set too short, it can cause harm. So then, how do you respond actually to this gap? And well, one of the options is to actually put in more caring effort to make sure that the patients get attended and get really the attention that they need in order to heal better. And business developer 1 characterized this whole loop here as the nurse to patient ratio is extremely low. There's a high risk of negligence due to system load and burnout. So I think that also characterizes the key loop characteristic here of this more care loop. So as a response of this care delivery gap, we make sure that there's more caring effort. However, you can also respond to this care delivery gap by saying, hey, we won't be able to manage with our current capabilities. We need to up our game in order to really become better in the future. And then you can actually spend effort on improving quality of caring. And Foreign Health Worker 4 gives an example of such an improvement. Like, parents are the best monitor for a baby. Involving them in the care process makes them feel responsible. Teach them how to observe. This saves work. And then the next variable in this loop is productivity of the improvement effort, which is also strongly influenced by the interrelatedness of this of the low resource setting. So when I was talking to trainer True, he talked about influence of beliefs and practices. And he said, society is built that way. That's the culture. Making your cousin a director is not seen as corruption, but taking care of family. And that's something that I, at least from my point of view and my cultural biases that I have, would think is wrong. But that's how the society there operates. And of course, I have to respect that. Like, that's their way of working. So then the last variable from this better caring loop is quality of care at the ward. And this quality of care at the ward determines how much of the caring effort also is converted into adequate attendance of care. And Foreign Health Worker 1 explains one experience he had when there was very bad quality of care at a ward. He said there was no proper organization why what babies were put where. Mix-ups happened. So that means that some people go home with a baby that's actually not theirs. So the key characteristic of this better caring loop is really conversion of this improvement effort over here to quality of care in the operation is uncertain and involves delays. And this delay I will come back in a few slides. So then the last loop, and only one variable is added here, but it's a very critical variable, and that is capability erosion in low resource settings. So these capabilities have a natural tendency to erode, and this is further complicated by the uncertainty that a low resource setting brings with. So as an example from Foreign Health Worker 3, because the salary is low, many health workers have second jobs, working on a farm, cooking, or owning a shop, etc. They're a bit overasked. So there's a lot of pressure on them. And the key characteristic here really is how much of this, so this arrow, so how much effort is going into improvement and how much will stay with the caring effort, aka how much will this loop get versus the better caring loop. And that's the trade-off that you make here. And if that's more, and if too little goes to the improvement, aka more to the caring effort, more care, then the ward by itself will come in a vicious cycle with the focus on firefighting, where you keep chasing the next fire to stutter. However, if there is a good balance and you understand how much improvement effort you have to give in order to challenge this erosion set here, a ward can arrive in a virtuous cycle with focus on systematic and continual improvement. Okay, so those were my results, and now I will cover some of the implications that I found in my study. And first of all, I actually want to highlight that there is prevalence of this capability trap model, which was developed in manufacturing in the US, that it could also be applied in work settings in low resource settings with a lot of work pressure to perform. So there's prevalence, and this low resource setting has a negative effect on how much these capabilities can increase and how much these capabilities erode. So it makes it more complicated to actually escape this trap. I will come to that in a few slides. And as I mentioned, I also had an implication for SDG 17's partnerships of the goals. And implications that I found were really that these low resource setting complexities must be considered before you can increase the effectiveness of implementation of capacity building efforts. And capacity building is something that you need in all the SDGs in order to make sure that these countries are able to build the capacity that they need to reach the targets that we set for them. So in this case, the 12 deaths per 1,000 live births. So healthcare in a low resource, there's also some implication on healthcare literature in low resource settings. First of all, this framework offers an analytical structure to assess the success of certain interventions, and it will help hospital wards to raise awareness for the level of organizational resilience needed for when something like a shock hits. And this way you can keep serving all patients in a quality manner. And this capability trap model, together with the process knowledge, identify critical care capabilities that can be the foundation of a learning health system. So admission, monitoring, supportive treatment are all capabilities that you need in order for a ward to function well. So one important practical implication is also that there's this thing called a worse before better dynamic. One must be willing to drop the current performance to proactively free up the resources to improve the long term. And I can illustrate this by the following 3 steps. So first of all, one needs to invest in improvement effort, which drops the performance. Here you see the adequate attendance of care dropping. Then, during this conversion of the improvement effort to quality of care, there's a payoff, but this one is very much delayed. Only roughly here 3/4 of a year later, there is this payoff of this delay in this diagram. However, overall the improvement will have increased because if you build on this capability and this actually sticks to the ward, it actually gets a lot better after this painful period. But during this painful period, you need to go through as an organization. So Lanijs and Sturven also offered a 5-step approach on how to escape such capability traps. Firstly, you need to recognize and prepare for the worse before better dynamic. An investment in these capabilities must rise above the erosion. And however, performance of all these performance of only the ward capabilities depends on a lot of other capabilities to survive. And for example, the cleaning must also be done inside a hospital. Otherwise, patients will keep getting affected and more care is needed. And improving all these capabilities at the same time inside of a whole hospital, so not only a ward, is by itself a crucial capability, which is often the duty of the hospital's management. And what's also very important is to reinvest the initial savings in further improvement, because if you subtract them from the freed up resources, you run risk of falling back into this trap. And you can also identify investments with a very short delay time that this worse before better period actually becomes negligible. And you need to keep utilizing these freed up resources for further investment. So to then close off by answering my research question, it's first of all very important for health workers to acknowledge and recognize that their capabilities are stuck in this trap, and that they must invest in it and understand how this erosion manifests. And investments of all these capabilities, also adjacent to this human and knowledge capabilities, must rise above erosion for all. And reinvestment of these initial savings to further keep improving the knowledge and the human capabilities at the ward is very critical. Otherwise, you can as easily fall back into it with all the effort you've put into escape it. So with that, I would like to conclude my public presentation.